welcome from Johannesburg, South Africa to this, the final edition in the CME Master Series on Fibrodysplasia ossificans progressiva, or as most of you know it, FOP. I'd like to extend a very special welcome to our first guests ever, the general public. FOP warriors and their families are also able to join the series now. And again, a very warm welcome back to all the healthcare professionals. I know many of you have been with us on this journey from the get-go, and it's just lovely to see you back in the room. We have grown the community of healthcare professionals who are now watching the series and engaged with FOP to over 300, so that is really thrilling for us as the Tin Soldiers team. I'm Odette, by the way, and our mission as the Tin Soldiers team is really to help shine a light on this debilitating and quite devastating condition, but also to, and most importantly, to really drive the search for people living without a diagnosis, and in other cases people living with a diagnosis who are not yet connected to the incredible global support that exists for this condition. So again, thank you for joining us. We are thrilled, I'm just looking at the map, to be invited to be we're thrilled. I can see from the map now we've just reached 126 registrants for tonight's session, and they're from all around the globe. And I'm just going to give a shout out to the countries that I can see joining us: Algeria, Argentina, Australia, Brazil, Canada, Hong Kong, India, Israel, Italy, the Netherlands again, Norway, Portugal, South Africa, Spain, Sweden, the United Kingdom, and of course the United States. So thank you, every one of you, for being here with us tonight on what for us is a very special edition, because this webinar goes beyond pure medicine, firstly, but also because not only is it our last in the series, but it is the first that is open to people beyond the healthcare professional circle. The caring is part of the cure is the theme for this webinar, and it is led by Dr. Fred Kaplan. It will be followed by a very special roundtable discussion with a very special group of guests: Dr. Genevieve Boujal, Dr. Carmen de Kuntel, Dr. Patricia Delay, Dr. Marilise Eckhoff, Dr. Elizabeth Ho, Dr. Fred Kaplan, who I believe has some Wi-Fi issues, so we're really hoping he'll be able to join us later, but he might not be able to. He is trying to get online. Dr. Kabashni Tendrahan, and then also Michelle Davies, the Executive Director of the IFOPA, and Kelly Duplessis, who leads Rare Diseases South Africa. Kelly, I know, is affected, as are we, by a city-wide power blackout. We have generators on, which is why we can join you, but she doesn't have one, so we hope she will be able to join us later. So crossing very shortly to the presentation from all these wonderful clinicians from around the world. We do hope you enjoy listening to their stories, and also the stories that they will share about very special patients that they have connected with in their experiences. If you have any comments, please post them, and very importantly, questions during the presentation. Please post them as you think of them, so that we can make sure we share them with the relevant speakers and guests tonight. Thank you so much again, and we hope you enjoy the presentation. Welcome to the journey.
It was on a day in September 1988 when I met a child with FOP. It was a 2-year-old child. I saw this child, and in my mind, I projected forward in this child's life what it might be like. And I put myself in the place of those parents and those families. Every time I see a child with FOP, maybe it's because of that sense of the catastrophe that FOP is, that I bond with these families, and it's a permanent bond. I'm an orthopedic doctor, and I've been involved in the care of FOP patients and in basic and clinical research for 35 years. I have no slides today, but I would like to tell you a few stories. The message of all those stories can be summarized in 6 words: caring is part of the cure. I was first introduced to that concept when I was standing in line in a hospital cafeteria the day before I started my clinical rotations in medical school. I was nervous that I didn't know enough medicine to enter the clinics. And I told that to a nurse who I knew, who was standing in front of me in the cafeteria line. She smiled and turned to show me the button on her white coat. The button read, "Caring is part of the cure." "It's the most important thing you need to know," she said, and she was right. It's one of the most important things I ever learned. From the very first day that my colleagues and I began the FOP journey many years ago, caring has been part of the cure, and it remains so to this day. My colleagues and I long ago set a research goal of determining the cause of FOP at a molecular, genetic, cellular, and physiologic level, and then using that knowledge to develop better treatments and eventually a cure for FOP. But in order to build the bridge from cause to cure, it is necessary to care. Caring is the integral link, the immutable bridge that spans the gulf between cause and cure, and the place where we as physicians and caretakers need to focus our efforts for the benefit of FOP patients throughout the world. Caring is part of the cure. As you have already heard from my esteemed colleagues, the clinical diagnosis of FOP is extremely simple to make if you are aware of the condition, and you are undoubtedly all experts already.
There we see the famous toes of Joe. And the one thing that we noticed is that the toe is missing that joint right in there. So it bends here, but it doesn't bend here like the thumb. Now, like, can you bend? Yeah.
FOP is one of the rarest conditions in the world. It affects about 1 in every million individuals. The road to a diagnosis is long and tortured in most people with FOP. Most doctors have never heard about FOP, have never seen a child with FOP.
I've let go.
If you have a child who has malformed great toes and develops lumps and bumps that progressively form extra bone or heterotopic bone, then the diagnosis is FOP, and it can be confirmed with a simple blood test. The point of diagnosis can become and must become the point of care.
The swelling goes down, and a piece of bone is left, and that bone is just like every other bone in your body.
Connecting the patient to the community, building bridges, ending isolation, using the tremendous resources available at the International FOP Association, the International Clinical Council on FOP, and many national and regional FOP organizations to bring the patient into the FOP community so that they are not alone. Caring is part of the cure. We need to find people with FOP, diagnose them properly, and connect them to a strong global FOP support network that already exists. That costs nothing except the time to care and can prevent harm and isolation, lessen misery and suffering, afford participation in clinical trials, empower education, and build a global FOP community. The proper diagnosis is critical, but it does not stop there. Caring is part of the cure. As physicians, we must become sensitive to FOP beyond the diagnosis. Our journey with FOP does not end with the diagnosis. That is where it begins. Even with successful treatments, FOP will be present as a lifelong concern. FOP progresses in several stages, and one occurs before birth, in the womb. The signal that causes the body to form unwanted bone after birth is the same signal that prevents the joints from forming properly before birth, in the womb. And it's not just the big toe, but the joints of the spine and the hips and the knees and ankles, all throughout the body. Many of those joints actually do form, but wear out long before they should. They become arthritic and fuse, even without bone forming around them. It is presently unknown if medicines that will hopefully prevent unwanted bone can affect the long-term fate of those joints. Perhaps so, but perhaps not. Even if we are able someday soon, hopefully, to stop the extra bone formation and even remove some of the extra bone under cover of an effective medication, it is entirely uncertain that we will be able to reverse the long-term degeneration of the joints. FOP is not just a genetic condition or a physiologic process, but a human experience. Living with FOP is a lifelong issue.
Dificuldades, eu não sofro nem a metade do que eu sofria. Tratamentos com todas as medicações.
E foi constatado que ela tinha um tumor benigno agressivo.
There are many emotional issues around independence, and that gets harder and more complex as individuals with FOP mature into adulthood. There are experts in FOP all over the world, as well as families who are far along on the journey, who are available to discuss, ponder, and render advice about the care of FOP. Resources abound. It is unrealistic to expect every physician to be an expert on FOP.
And do you think they're becoming bigger? The same lumps becoming bigger?
Definitive treatments will advance slowly, but caring is always possible, always needed, and desperately desired by FOP patients everywhere. Caring is part of the cure. But why care? Certainly for the individuals with FOP, it is critical and could be life-saving, but it goes beyond that. Let me tell you a story, a very old story. The year was 1657. The place was London. A letter arrived at the home of Dr. William Harvey, a man whose life was distinguished by one of the greatest discoveries in the history of medicine, the discovery of the circulatory system. But the letter to Dr. Harvey had nothing to do with common problems of the heart or blood or circulation. The letter invited Dr. Harvey to consult on a gentleman with an extremely rare condition of the urinary bladder. Dr. Harvey was old and in failing health and declined the invitation, but he clearly recognized the value of such a noble pursuit. He reached for a piece of paper, dipped his pen in the inkwell, and wrote these words, perhaps some of the most prophetic words in the history of medicine. He wrote, "Nature is nowhere accustomed more openly to display her secret mysteries than in cases where she shows traces of her workings apart from the beaten path. Nor is there any better way to advance the proper practice of medicine than to give our minds to the discovery of the usual law of nature by the careful investigation of cases of the rarer forms of disease. For it has been found in almost all things that what they contain of useful or applicable nature is hardly perceived unless we are deprived of them or they become deranged in some way." But why is that so? Why are the rare conditions so instructive of more common ones? The answer is very simple. Rare diseases provide rare clarity in a field of chaos. The specific nature of rare diseases, like FOP, often permits a causative genetic factor to be isolated in a complex regulatory network, thus identifying and defining the network itself. Such insight is often the catalyst for developing effective drugs for some of the most common diseases of mankind, like hypertension and diabetes and asthma and high cholesterol, that affect millions. Nature does not use different genes, molecules, and pathways for common conditions than it does for rare ones. Rather, it is often the rare diseases, like FOP, that actually reveals which gene, molecule, or pathway nature hijacks in its common infirmities. It turns out that the key to the rare disease is often the key to the common one. The key to the closet is often the key to the kingdom. Let's take FOP as an example. It's an exceedingly rare condition, as we said, certainly one of the rarest conditions in the world. And yet what we have already learned about FOP is relevant to every condition that affects the skeleton: osteoporosis, arthritis, fractures, congenital defects, to name a few. Conditions that affect hundreds of millions of people throughout the world. Answers to FOP are relevant not only to those with FOP, but also to those who form extra bone due to more common conditions such as civilian trauma, war injuries, head injuries, burns, and strokes. And this may come as a surprise, but as many as 15% of those who have heart valve replacements or hardening of the arteries have bone that is identical to FOP. And there is a flip side to the coin as well. Perhaps the FOP gene discovery can be harnessed to produce extra bone where it is wanted and needed, like in children born with bone defects, in fractures that do not heal, in osteoporotic hip fractures, in civilian trauma, like automobile accidents with large bone defects, or in those who need spine fusions, conditions that in some cases affect tens of thousands of people worldwide, and in other cases, millions. The examples and lessons of rare maladies are profound and endless.
I like the hockey and I like to play baseball.
Once again, the key to the closet is the key to the kingdom. In the last paragraph of an essay in The Lancet, nearly 100 years ago, Sir Archibald Garrod, the father of metabolic diseases, stated, "We may feel sure that in the future, as in the past, there will be many who will try to solve the problems of the more common diseases, the control of which is of vital interest to the community at large. But let us hope there will always be some who seek to solve the riddles of rare maladies. And to that I will add, to care for those who have those rare maladies, like FOP, who might otherwise be neglected or worse, forgotten."
Eles podem brincar em outro lugar, mas eu não posso. Eles podem correr atrás de pipa, eu não posso.
How fortuitous that nature would put such a skeleton key not in the hands of the commoner, but in the hands of the rarest among us. The key to the closet is the key to the kingdom, and Carrie is part of the cure.
I think that sometimes caregivers feel helpless when they can't cure a patient, so they forget about the other things they can do, palliative care and ongoing support. Any child with a chronic illness or a disability should have a medical home, some place where the family feels that they actually belong and they can easily get hold of help if needed. I first met Kira Betswe a few years ago in the pediatric outpatients department. Her mom brought her looking for a school for her.
0, 1, 2, 3.
I felt really shocked to see a child with such a serious condition, and it was at quite an advanced stage. And at the same time, excited because it's such a rare condition to see, and at the same time, very sad and fearful for Kira Betswe because she's got such an uncertain future. Her mom couldn't name the condition, but she said that the doctors had told her that there was nothing they could do for her child.
I didn't know what is an FOP children. The minute she explains to me, I just wish that we can die, me and my child. She told me that this is the starting. She's still gonna get worse.
She was just told, "We're very sorry, there's nothing we can do, and your child is just going to get worse. And so they gave her no hope and no support.
Whenever she gets hurt, there's a bone growing there, and then the FOP makes her difficult to breathe with her lungs.
The story goes that Kira Betswe grew up as usual. She was running around as a little child, and one day she fell at the creche. Her mom took her to the hospital, and she said that she'd broken a bone. And from that time on, she never walked normally again. Gradually, she lost her function, and she underwent some orthopedic procedures, didn't get better, had recurrent bouts of severe pain, and then eventually ended up in this condition where she was unable to move her arms and her legs and her neck. So by the time I saw her, she was basically frozen in the shape of a chair, and she had fixed deformities. She couldn't move her arms or her legs. But she has these huge big eyes that are very expressive, and she takes in everything around her, everybody, what they're doing, and she's got this little sense of humor, a great sense of humor, and she's always very friendly. She never complains, and you just can't help falling in love with her. I felt angry that nobody had referred her earlier, at least to all the resources that are available at the hospital. So, and we could have helped her, even if not to cure her, we could have assisted with her symptoms, with her pain, and put her in touch with a lot of support systems. I felt that perhaps the doctors that saw her had felt helpless themselves.
I thought maybe it's a witchcraft or something. I still took her to some sangomas, witch doctors, churches, thought maybe something will change. Most of the sangoma, they were giving us some stuff to use. They say, no, it's a witchcraft. She'll be okay, but she's never been okay.
She was desperate. She was very lonely. She didn't know where to turn, but she knew that her child wanted to go to school. So that's what brought her to the hospital. She wanted a letter to the Department of Education. Julia and Kira Betswe live in a very poor area with very few resources, and the local schools, you can imagine that there are up to 60 children in a class with one teacher, and most of the children walk to school. So there would be no special resources available for Kira Betswe. The special schools are few and far between. Luckily, she did find a school that is equipped for children with physical disabilities. And there's a very nice little community that she's part of. So now she loves going to school. She has friends. She loves her teachers. She has learned to read and write. And that was, you know, she just wanted to be a normal little girl going to school like everybody else.
Kaska W, Kaska.
We immediately referred her to our occupational therapist and our physiotherapist. So the occupational therapist assisted her with a wheelchair that she didn't have until that time, and assisted her with tips of how to be more functional in everyday life. So all her activities of daily living, making it easier for her to do things for herself, because she really wants to be as independent as possible. So giving her tips of how to brush her teeth, how to feed herself, how to scratch her toes with a stick, or how to dress with aids. So they assisted with small things like that that can make a big difference to your quality of life. The physiotherapists can help, especially with the breathing exercises, because the chest wall becomes frozen. They have a restrictive lung disease, and it's important that they keep the rib cage as flexible as possible, and the physiotherapist can assist with breathing exercises. So besides occupational therapy and physiotherapy, we referred her to social work, and they assisted her in applying for a childcare grant, which is like disability grant for children, and that helps the family to survive.
When there's no food, it's very painful. It's like you can say, as long as the child eats, then you can drink water and sleep.
Then we have a psychology service. We've got to think of her mental health and mom's mental health. So it's a whole multidisciplinary team that's going to help children like this. And part of the multidisciplinary team, you should have a dentist, because the dental care is very important. Eventually the jaws can get fixed, and then it may be very difficult for the dental care. Orthopedics surgeons should be involved, mainly to make sure that unnecessary operations are not performed. And palliative care teams are available often.
I'm very happy about their help. I'm so thankful they helped me.
The mom, Julia, she did say, "Thank you so much, doctor, because now I feel that I can help my child more." It helps if there's one person that's responsible for them, knows about them, cares about them, is interested in them, and is available for them. So they're not alone.
She's everything. She's the one who keeps me going. So I just hope that she stays like this, not getting worse. I pray to God to help us to be only like this.
I think it's very important just to always have hope. It reminds me of a saying that has a lot of meaning for me as a medical professional. That is to cure sometimes, to treat symptoms often, but to comfort always. And I think that's the base of palliative care. As a doctor, you don't have to cure a condition to be helpful.
I remember Mr. B.
Remember Mr. B?
Yes.
He's a funny guy.
I had a mission to find every single patient in Brazil that was living without knowing what their disease was. It's not me as a doctor, I'm not amazing. We are all amazing as doctors if we look at patients like human beings. Hello, my name is Patricia Dalai, and I am here today to tell you how important it is to take care of an FOP patient and how much this is part of his care. I am a dermatologist. I work with FOP since the year 2000. And you may be wondering why a dermatologist, a skin care doctor, is taking care of someone who has bone diseases. Because we are not just dermatologists or pediatricians or orthopedists or whatever. We are doctors, and we must take care of patients, take care of human beings. And that's where my journey with FOP began, until now that I am part of the ICC. My journey with FOP began in the year 2000, when I went back to the medicine school, just because I wanted to learn more about dermatology and internal medicine. So I was there for some years to study a little bit more. And there was that girl that was coming, and she had lumps and bumps all over her body, and her body was becoming stiff. She was becoming a statue in front of my eyes, and nobody knew what she had. And that was so frustrating. And I remember that I had a teacher that said it was scleroderma, and I was studying, and I said, it's not it. And because of this frustration, I took this patient all over the medical school, trying to see if someone else could recognize what was going on. And someone said, hey, this is fibrodysplasia ossificans progressiva. And I said, what is this? She said, this is FOP. All her body is going to turn into bones, and she's going to form another skeleton. I said, okay, let's do something. Let's change this reality. And nobody knew what to say. So at that point, it was so frustrating that I said, come on, you can come with me. I talked to her mother and I took her to every medical school in São Paulo. And nobody knew what to do. So I started to feel very uncomfortable. And I told her mother that if I was a dermatologist, but I could do something as a doctor. So I started searching on the internet. At the year 2000, the internet was not so powerful as it is today. Google was starting. And I started searching first in Portuguese, then in English, and it took me to the IFOPA, the International Association of Fibrodysplasia Ossificans Progressiva. Okay, it was late at night, and I said, well, let's write something to them. I wrote that I had this patient, and some days later, I received an answer saying that they were going to put me in contact with Dr. Frederick Kaplan. And it was like if a new world was opening in front of my eyes. I was invited to go to the third symposium on FOP, and I saw a lot of people like my patient. And I was so happy because I would be able to give her answers. And this is where the caring starts to be part of a cure. I didn't have a medicine, as we don't have a medicine yet, but I had something to tell her, what she had, to give her hope, to give her options to live. And this was the most important thing I think I ever did in my life. At this symposium, I've learned a lot, not only with Dr. Kaplan, but with a lot of other physicians. And I realized that there was so much more to be done. I had a mission in front of my eyes that was to find every single patient in Brazil that was living without knowing what their disease was. To improve, I had to improve the care for these patients. They were alone. People were trying to help them, and instead of helping, were doing harm. They were doing biopsies, surgery, and so many other things that if you do to an FOP patient, you cause even more pain and more immobility. So this was something important. I would have to go back home and educate doctors and other patients and the community, the society about FOP. And most of all, at that time, we didn't know what was the gene that was causing the disease. So we had to find multi-generational families, families that had more than one children with FOP and also the father or the mother, to find the gene. And this is where my journey with FOP began. I knew it was a big stairs. There were big stairs and I was taking baby steps, but it was okay. You know, when you start working with FOP, it's you and you alone. And you have to open the eyes of people and say, hey, pay attention. You just have to look at the big toes, to look at the extra bones. And you have to be strong to make a difference in the life of so many patients. And when I arrived home from Philadelphia after learning so much, I was going to every hospital and looking at the old files about patients. I was looking for FOP, for malformed big toes, for heterotopic bones, and finding one patient, let's say, each 2 months. And it was such a happiness, not only for me, but also for my family that at that moment was already involved. And with the help of Dr. Kaplan, I was always checking each patient that I found. Then suddenly we went to TV to make big presentations about FOP, then to newspapers, then to radios. You never stop. Once you start working with FOP, it's a passion because you know that you're making a difference in people's life. Unfortunately, by the time I found many patients, bad things were already done because many doctors didn't know that surgery couldn't be done, that intramuscular injections couldn't be taken. So many people were already suffering because of not known education about FOP. So it was urgent to educate doctors patients, and the society about FOP. And it was with a great joy that with the help of many friends around the world, in 2003, we did the first Latin American FOP meeting in São Paulo. At that time, 28 families came to São Paulo, and it was an amazing experience. We taught them about FOP, and we had at that meeting the first multi-generational family from Brazil that was crucial for finding the gene. But most of all, people were happy. For the first time, I could see the faces of my FOP patients, of the one that I saw individually. They were happy, they were learning, they were listening. Even the ones that I understood that could not understand all those medical words, they were paying attention. And again, I was not giving a medicine. I was giving information and giving them hope. Maybe not hope for medicine, but the hope of knowing that there is someone that looks like you, someone that has the same difficulties that you have in life. This is priceless. And so we see happy faces. And you know why those happy faces were there? Because we care. So again, it's not me as a doctor. I'm not amazing. We are all amazing as doctors if we look at patients like human beings. And most of all, I know that now we are in 2020 and many patients didn't make it. Some are not here anymore. But I know that they lived believing, having hope, that they lived in peace, knowing that everything that they could do about their lives was being done. In 2004, we understood that we had more to do in order to be heard globally, to make a noise, a real noise. We had to create FOP Brazil, a Brazilian Association on FOP. And that's what happened with the help of so many families that are still with us right now. With the name FOP Brazil, we created printed materials that we were spreading all over universities and everywhere that we could put it. Just looking at the big toes, at the heterotopic bones, someone could just recognize an FOP patient. And it's funny because most people would say, hey, how can I recognize someone that is 1 in a million? I mean, what is the chance of this person to appear on my way? And I have a funny story. I have a case of a mother of an FOP girl, and she took a bus, and it was the wrong bus. But then she was standing in the bus and she looked down and she saw big toes like her daughter's. And she called me immediately and she said, Doctor, I found an FOP girl in the bus. And I said, this is not true. Come on, this is too much coincidence. And it was true. So just by spreading the word, hey, look at those big toes, you may find someone that is really in need of care. We created a website that is still online and where you can learn about FOP, where you can find information in Portuguese. And we also had the help of many celebrities, like football players, like actresses and singers that were wearing the FOP t-shirt and also the FOP bracelets. And many, many patients keep appearing. And then FOP Brazil grew. It was not 1 patient anymore. It was not 2 patients anymore. We had many, many patients. And FOP Brazil grew a lot. And now we have the involvement of families and of friends around the globe. In 2019, the situation in Brazil was, Brazil has 202 million people. FOP is 1 in 1 million people. Brazil must have about 100 to 135 patients. In 2019, we knew of 90 confirmed FOP patients, and now we know about 99. So we still have a lot of people to find, and we need to educate more and more doctors. Just to think that a doctor in the delivery room can recognize those malformed big toes and call us is very, very important. So why get involved? I think many people ask me, it's so rare to find someone with FOP. Why should I fight about it? So first, because it's easy. So it's just to look at the toes, just to look at the extra bones, and you are going to think, hey, this is FOP. I cannot make a surgery. I cannot give an injection to this child. I have first to check if it's really FOP. So it's easy. It's not going to take too much of the time of someone. Second, the diagnosis costs zero. You don't have to do any kind of tests at the beginning. So all you have to do is think about FOP. If you have FOP in your mind, you are going to think about it, and this is enough. Then it's also a pioneering initiative. I don't think anyone where you are thought about it. So if you can be the first one to help to change the life of so many. And you're going to give a better care for these families and patients. We know that there is a big staircase in front of you. We know that. And you're going to start it alone. But with time, you're going to have a lot of people with you, with international collaboration, with patients' engagement, with families going with you. You are not alone if you decide to go for FOP. And finally, I would like to end with some words, this presentation, that says something about dreaming. I know that every presentation people end with something intelligent, but this is not what I want. I think as doctors, as human beings, we have the power of dreaming. And dreaming can change not only your life, but the life of the whole community. So dream that you can change the world, and you're going to make it happen.
At Krisani Baragwanath Hospital, we actually the third, I think, largest hospital in the Southern Hemisphere. So we do service a lot of patients. And to give you an idea, we actually have close to 30,000 deliveries of newborns a year. Our patients come from low, middle income environments and backgrounds. They live in squatter camps, rural areas, and they don't have access to a lot of amenities, water, electricity, and they live very far from tertiary facilities, from specialists that can treat them. And also, in the end of the day, do they have a plate of food? And we need to take into consideration all of those problems when we are trying to treat our patients and manage them. I'm Professor Kibashini Tanrai. I work at Krisani Baragwanath Hospital. I'm a pediatric endocrinologist, and my special interest is in metabolic bone diseases. So I treat children with rare bone diseases, as well as the common bone diseases such as osteogenesis imperfecta and rickets as well. Today, I'm going to tell you about one of our South African patients, and she's actually faced trials and tribulations in the first 2 decades of her life already. And despite all of this, you always see her smiling and being strong. And it's been almost 20 years that we know this patient, and you develop that bond. When she first presented, she had the swelling on her neck, and she was actually seen by a private pediatrician who investigated her for tuberculosis of the spine and also for leukemia. And he then did an MRI scan of her neck and chest, and she was actually then diagnosed with the condition at that age and referred to us. So it's a little 2-year, 10-month female who was referred to us in 2004, and it was actually the first patient that we had seen in our unit. So we had the images of the MRI scan that the private pediatrician had sent to us, and it did confirm that she's got connective tissue swelling that was running down the neck. So these images show you that she's got this iso-intense connective tissue swelling. So it's iso-intense with muscle. And it's actually more prominent on the left side of her chest as well. T2 weighted sequences showed increased signal intensity of the connective tissue, and with gadolinium, there is intense enhancement. So the radiographer had reported it as being suggestive of fibrodysplasia ossificans progressiva, and that the ectopic calcifications will develop more in about 4 to 6 months' time. On her clinical examination, when she presented to us in 2004, she had normal anthropometric measurements. So her weight for age Z-score as well as the height for age Z-score were within the normal range, as well as a head circumference. What we noticed was a swelling on her forehead, as she had fallen about a week ago before she had come to see us, and also the firm, hard swellings that were already present along her back especially, and along the side of her chest wall as well. So I think when we see something like that, you think of more malignancies. I think most people think of malignancies first. Many of them don't know about heterotrophic calcifications if you haven't actually seen it yourself. But generally, I mean, you shouldn't really see a lot of bony prominences as that, but more bone conditions or osteosarcomas and more malignant bone abnormalities. Nothing intrusive was done, and that's very fortunate for her. In order to confirm that we have fibrodysplasia ossificans progressiva, we have to do radiological x-rays as well. And as you can see from 2004, there weren't a lot of changes that were noted, and it had progressed already in 2006. So the images are not that clear. The quality might not be as good as in 2004, but basically there was heterotrophic ossifications on the right side of her axilla region. And then in 2006, you can see it's more ossified. And then also you can see that there's extension, quite significant involvement, more so on the left side compared to the right side as well. So I worked backwards by presenting the radiological findings first. Clinically, she does have the congenital malformations of the toes, the big toes, with shortening of both her big toes, which is pathognomic of the condition. And then in the subsequent photos, you can see that she's got limited abduction of her shoulders, but she can flex her elbows. And then the back, you can see that she's got quite significant bony prominences on the right side below the scapula and on the left side along the chest wall, as was confirmed with the MRI findings. And it actually extends lower down onto her back as well. Over the years, her disease progression and management is listed here. We started her on oral pamindronate infusions quite early in 2005 when she was 4 years of age. Thereafter, she developed the lesions on the scapula and mainly on the back. And then she started developing lesions on the right hip as well as in the superior iliac fossa region as well. And she started giving us a history that she was falling quite often. And then she developed lesions on the occiput region and the buttocks. And that was quite, I think, debilitating for her and painful, because she then requested that we try and get her a ring cushion so that she could sit nicely at school, because it was quite painful and she was feeling very uncomfortable. So we got the occupational therapist to assist us with a ring cushion for her at that stage. And then we did change her to zoledronic acid infusion, which was actually a more convenient and more cost-effective therapy as opposed to pamindronate. Cost-effective because she didn't have to spend 3 days in hospital with pamindronate, as opposed to a half-an-hour infusion with zoledronic acid and you go home. And also the visits were less frequent. So with pamindronate, you would do a 4-monthly visits, whereas with zoledronic acids, it's a 6-monthly visit. And I always recall her sitting in the front of the door of Metabolic Bone Clinic and looking out the door and waiting for her mum to return when she was on the pamidronate infusion for 3 days. So she'd sit there on the chair, wait every day for mummy to return and take her back home. And that was so sad to see. And I think when you see all of that happening, it drives you to do the best for your patient. And especially if you don't have treatment available as well, which sometimes we don't. And it gives us grief, it gives us stress, and we want the best for everyone in the end. So subsequent to the intravenous infusions, we then saw that she started developing lesions in her elbows, which were worsening. And then I think the turning point was when she developed the submandibular swellings. And she was around 15 years of age. At this stage, we then started prednisone for the flare-ups and non-steroidal anti-inflammatories. I did get very concerned. And I was wondering now, what should we be doing next? Is it going to resolve? Is it going to cause airway obstruction? How astute should we be in terms of managing her? And then obviously the guidelines say that it does sort of settle, they can eventually swallow, but there is that risk of airway obstruction. So we treated her with the prednisone and she seemed to have responded. And she does have some residual ossifications or swelling there on the neck. And then now recently I've seen her in 2020. And what has happened is that now she cannot sit and she cannot abduct her right arm completely. So she has deteriorated. And she's also lost a lot of weight. She's lost about 5 kilograms in the last year, and she's developed quite a significant microcytic anemia. And this is probably related to iron deficiency and a poor diet that she's taking. She also complained of constipation at one stage, which is also related to not taking in adequate fluids. So that was the progress and where we are with her at this moment. So we're at a stage where she's now progressed quite significantly, and all that we still offer her is the bisphosphonate therapy. So now, as she grew older and she had tragedies in her life where her father demised in 2016. The mum was the breadwinner of the family. And then mum asked me questions when she started having these submandibular swellings. So I said that was the turning point when she was 15. So mum asked me questions as to, is Keisha going to die? And when? And how long is she going to live? Is she going to die before me? She also struggled financially, and she did also express that to me at one stage. And I think all these stresses had eventually succumbed her mum to taking an overdose and left our patient to be on her own. So subsequently to that, she turned 18 and she was then assisted by her teacher or guardian. And I think we have to be thankful that she had someone like that to help her. And she took her to the SASSA offices, so the South African Social Security Agency, to apply for a disability grant. So when the state doctor had seen her, she was the patient that always has the smile on her face, and he or she asked the patient to touch her toes, and she did so, and he didn't, or she didn't think that our patient had this chronic disabling condition, and questioned the diagnosis despite me actually sending medical records and articles explaining what the condition is. So then she had to take in some x-rays, and they then subsequently had given her the grant, which she has to renew on a 6-monthly basis. So I think holistic care in our management of patients is very essential and important, or mandatory. And it's a multidisciplinary team that we need to have on board to manage these patients. So the physicians alone cannot manage these patients. And obviously we don't have the miracle treatments, or we give supportive care in certain conditions. We provide what we can. And if there's a treatment or a cure, we will provide it. But with conditions like this, there are allies that need to help us. So the physiotherapists, the occupational therapists, as well as the speech therapists. So as I said, she needed a ring cushion to help her, which the occupational therapist provided us with. She needs physiotherapy to assist her in physical daily activities. She needs a speech therapist who can also assess whether she is swallowing properly and whether she can actually eat well. And also they do get hearing problems as they grow older. So that's also a problem that needs to be addressed at some stage. And then the chronic illness itself is a financial burden upon our patients. So whom do we refer them to? Our social grants services help us there. And then the psychological aspect of the disease is something that we ourselves as clinicians cannot deal with. We have to have a psychologist to assist us. We have to have psychiatrists if they go into depression. So all of that is very important. And as you can see with our patient, the financial burdens was probably there, and also the mum needed support as well. So I think we forget about the parents and the caregivers, the psychological aspect of dealing with a child with a chronic illness. So in the end of the day, what is needed is a multidisciplinary team in your offices, one place, because if they're coming from far, they cannot travel long distances up and down to make an appointment with a psychologist on another day, with an occupational therapist on another day, and with your physician on another day. Everything needs to be done at the same time. And that is what holistic care is all about.
I didn't know anything about the disease at the beginning, just the few things that you can read in books, but this is not what they really suffer, what they're going through. I was surprised that many patients, especially the patients that connect with me through emails, if I answer those emails quickly, without doing anything really active in terms of treatment maybe, just to talk to them, to listen to them, just I think sometimes it's enough. We are really part of a family, and it's not just a word, it's really what we feel. Thank you very much for the invitation to speak and be part of the Teen Soldier program. I'm Carmen de Cunto. I'm a pediatric rheumatologist at the Hospital Italiano, Buenos Aires, Argentina. And I've been working with the FOP patients since almost 20 years. And I learn a lot from them and from their families. And I'm actually taking care of patients and also in clinical research with the new treatments that are going on. Well, my story with FOP, how it started. My encounter with FOP was one case of serendipity, I think. Although I remember having seen the name of this disease in books during medical school, I had never had the opportunity to care for a real patient. A few weeks before I met Manuel, my first patient, I read a case report from Bolivia about a stone man sent for consideration of publication to Archivos Argentinos de Pediatría. And coincidentally, at that time, I was the co-editor of that journal. And that paper caught my attention in a particular way. A few weeks later, I found myself in front of this little boy who came with a history of lumps on his upper back and limitation of movement of his neck. The first thing I asked him to see when doing the physical exam was his toes. He had bilateral hallux valgus, bunions. At that moment, I had the certainty of his diagnosis. The paper I had read reminded me all the clinical characteristics of the disease. So I had no doubt about the diagnosis. I did feel, however, the burden of telling him and his parents what the diagnosis was and what the disease progression would be without the prospect of treatment at that time. So my journey began with Manuel and his family and has grown into almost 20 years working on and with the FOP community in South America. Manuel's parents are the most proactive people I know. They quickly were in contact with Dr. Kaplan and the international FOP community. They founded Fundación FOP Argentina and worked very hard to make all the information about the disease available for the public, trying to build a network among patients and physicians. They introduced me to Dr. Kaplan, to one of his famous clinics during an FOP international meeting in Orlando many, many years ago. That gathering really changed my view and understanding of what was going to be my role with the patients and their families, to care. My commitment was sealed. There was no turning back. So almost without realizing it, I began to receive referrals of patients with FOP or with probable diagnosis of FOP from all around Argentina and other Spanish-speaking Latin American countries. This journey that started with Manuel as a child, now a young adult at the university, has taken me to many places and meeting patients and their families from all around the world. And I'm now part of a global FOP community. I understand the true meaning of caring. Although as a pediatric rheumatologist, I was used to take care of children with chronic diseases, the encounter with Manuel made a great impact on my view on how to embrace life every day, not through the limitations, but enhancing the possibilities. Taking care of more patients with FOP gave me the chance to learning from them and to interact with many specialists involved in the very complex follow-up of that these patients require. These years have passed very fast, really. Building a well-known center for care of FOP at the Hospital Italiano de Buenos Aires, where I work, where the expertise and understanding of FOP keeps growing. At present, our center has FOP expertise, not only in rheumatology, but also in endocrinology, orthopedics, dentistry, physical therapy, and clinical trials management. To the 24 patients I follow in my country, I have to add the patients and families from other countries of Latin America, whose emails I receive and provide them support at a distance. Caring for children is always an adventure that makes us part of their growth and development. To follow my patient with FOP into adulthood has given me a sense of continuity and future, and made me an active witness to their lives. It has been said that to realize the suffering of another person by an illness, the physician must enter into the patient's world and see the scenery from his or her perspective. This is not an easy task, but knowing the journey that many patients with rare diseases have traveled helps me honor the stories of all my patients, no matter if they suffer from a rare or common condition. Thank you very much.
So care for us is 100% of the importance. There is always many things to do, including the follow-up, the care, but also very important school inclusion, and to make possible that teenager, the child, whatever is the age, to follow quite normal school life. Hello, so we are the French team and from Paris, from the Center of Reference for Skeletal Dysplasia, Dr. Alessandro Amadeo.
Nice to meet you.
And Dr. Geneviève Boja, belonging to the Center of Reference placed in Paris. And we are happy to present you one of the example of follow-ups that we have for FOP patients here. As you know, for us, it is very important to have regular assessments. Of course, we'll adapt the schedule of assessments to the age and progression of the disease in the patient. And all these assessments are linked with the local GP, physician involved in the patient's follow-up. So we have a schedule of assessments which is proposed for patients with various age period, and we of course try to adapt this to each patient. By instance, we have functional assessments with the cages, which is also used in several countries. We do geometry, renal assessments, and pain and comfort control. We would like today to explain maybe a bit deeper what is done for the respiratory function. This is a very important point. First assessment and then management on cases with insufficiency of respiratory volumes. So I will let Dr. Amadeo explain how this assessment is performed, and next what is done today to improve their function.
Hi, nice to be here. So first of all, I think that the main goal of our assessment is to prevent and try to treat respiratory complications in FPOP. As always, I like to say that every patient is different, so we will have a different approach depending on the severity of the disease. But on a ground level, I would like to say that the most important thing is trying to prevent respiratory insufficiency and prevent thoracic insufficiency. What we know so far is that in FPOP, there is an increased risk of developing a restrictive respiratory insufficiency, meaning that the thorax, the chest is too stiff to give enough volume and enough ventilation to the patient. This is something that develops over time. First of all, we will see that some patients have chest deformities, scoliosis and ankylosis of vertebral and chondral cartilage. And also they start to have ossification of soft tissues and muscles. This leads to a progressive deterioration of lung function. And the way we try to assess this depends on the age of the patient and on the severity of the disease. First of all, we try as soon as we can to perform lung assessment respiratory function, meaning spirometry and other function tests that allows us to detect which patients are at higher risk of developing respiratory insufficiency. Then, starting from age that depends again on the severity of the disease, we would like to do yearly PSG polysonography assessment, meaning to detect early nocturnal hyperventilation, the failure of the muscle to give enough volume to the patient, which appears early during sleep. So we would like to prevent and try to treat as soon as possible this complication. And the way we treat it is, of course, by preventing chest deformity, try to prevent chest infection, which is a matter of concern for most of the patients.
Bonjour, je m'appelle Frédéric, je suis la maman de Julia. On a commencé à avoir la VNI chez nous en 2013, donc Julia avait à l'époque 10 ans.
When hyperventilation is still is set up, we will treat them we offer to the patient an IV, which is non-invasive ventilation. It's a ventilation that we use for our patient, and we offer them the possibility to have a mask during the night, which is connected to a ventilator, which allows them to breathe more deeply and without further effort in order to correct nocturnal hyperventilation. All of this coordinated should be done on a scheduled follow-up, but we start as soon as possible. As I said, for non-function tests, we start by the age of 5 or 6 years old, and then for polysonography, we start at the age of 8 to 10 years old, and then we try to follow up this patient every year to detect early signs of nocturnal hyperventilation.
So our role as coordinator for these patients is to ensure that the patient follow what is proposed by the pulmonologist, and to support them, because at the beginning it is not always easy to be totally adapted to the machine. But what we can see now with the experience of a few years, it is the fact that they feel much better. They are better in the daytime. They have a better global concentration and mood in the daytime. They have less fatigue, and the quality of the sleep is better than before. So it is for us now something that is usually systematically performed depending of, as it was said, age and progression of the disease, but after the age of 6 or 7 years for the more advanced cases, but of course adapted to the deformities, and it is something quite new but very important help for the patients. So yes, today we wanted to recall about Julia, this young lady that we follow since the age of 2 years, very, very early in life. And because she has a significant deformity of the trunk with severe scoliosis, she had many respiratory events with several hospitalizations, including intensive care unit in the local hospital and also here. So we referred this patient, it was 5 years ago, something like that, to assess the pulmonary function.
Cette maladie chez Julia fait que son cou, ses épaules et les muscles de sa cage thoracique sont ossifiés. Et ça a commencé, ces symptômes-là, à partir de ses 3 ans. Le résultat, c'est que ses poumons ont une toute petite place pour fonctionner. Et bien qu'ils fonctionnent bien, avec ce volume très réduit, ça lui fait une respiration qui est toute petite.
I met actually Julia when she was 10 years old, and she already unfortunately had severe respiratory insufficiency due to chest deformities and ossification of the muscle of the chest. So we performed a PSG, a polysonography, who actually confirmed severe respiratory insufficiency and what we call nocturnal hypoventilation. And so we proposed to Julia to start an IV. At the first time, I should say that it was really challenging for Julia to accept the mask. So we had to arrange a few nights, at least 3 or 4, in order to acclimatize Julia to the fact that she had a mask and she should have to wear it all night long.
Pour vous aider à vous représenter l'insuffisance respiratoire chronique, imaginez que vous avez le nez bouché à cause d'un rhume. Ce sont des choses qui arrivent à beaucoup de gens, même bien portants. Ça gêne le passage de l'air et du coup ça freine l'intensité des activités quotidiennes, on va un petit peu au ralenti. Et la nuit, avec le sommeil, le rythme de la respiration est encore plus ralenti. Et dans ces cas-là, même quand on est bien portant, on est réveillé dans la nuit. On sait des fois pas trop bien pourquoi. En tout cas, on est gêné parce qu'on ne peut pas respirer comme il faut et on a un mauvais sommeil. Donc en fait, Julia, du fait de son insuffisance respiratoire, elle est un peu dans cette situation-là toutes les nuits. Donc, la ventilation non invasive évite à Julia les ralentissements de la respiration et puis lui permet un sommeil sans baisse d'oxygénation trop grave.
So it was really difficult, but I think that at the very end, what was the key of the success was to try to follow Julia and try to listen to what she wanted, and also to try to gain her trust and to really follow her step by step in order to de-dramatize this moment, which was really threatening for her. And so little by little, she began to tolerate the mask more and more. And now I think that we can say that she is not able to sleep without the mask anymore because she's really feeling better with the mask. And as Genevieve said, the main point is that we are going to correct nocturnal hyperventilation in order to make them feel better during the day and to improve performances on a cognitive level, but also physical performances during the day. So I think that the learning point, for me at least, from Julia's case, is that you should never give up and try to follow the patient in every aspect. Also, psychological aspects are really important in order to propose a treatment and try to follow your patient all over the treatment process.
Pour Julia qui ne peut pas bouger ses épaules, effectivement, ça suppose qu'il y ait quelqu'un disponible pour positionner le masque, mettre le harnais, comme on voit sur la vidéo qu'on a faite. Elle a trouvé il y a peu de temps une astuce pour pouvoir l'enlever, donc elle peut l'enlever toute seule, mais quand il faut le mettre, elle est dépendante de quelqu'un. Du coup, ça fait partie des choses qui l'embêtaient quand il a été question qu'elle ait la VNI toutes les nuits.
And it's true that now when she presents with respiratory infection or asthma crisis, finally you adapt the ventilation. You use this system on daytime added to the night, and things are much easier now. So for several points, it is a very important tool now in her follow-up.
Yes, and it should be, and I think that you have to consider to start to increase the knowledge about this complication and try to do a scheduled follow-up for this complication and introduce as soon as possible by NIV this possibility to improve night sleep, also daytime performances.
Now she had her graduation baccalaureate last year. She's brilliant at school. She is now in the university with excellent results and follow the studies in the same way than her friends. So possibly there is a great help from this ventilation.
Ah, est-ce que c'est pour la vue? Bah ça, tant que le corps est dans la même situation de petit espace, petit volume de respiration, j'ai envie de dire oui, c'est pour la vie. Même dans tous les sens du terme, c'est bon pour la vie. Ça implique d'admettre justement un peu plus de dépendance. Ça implique d'admettre l'insuffisance respiratoire. Et l'insuffisance respiratoire, c'est quand même assez angoissant. Donc voilà, déjà, ça suppose tout ça. Puis d'être dépendant de la présence d'une machine, mais en fait, une fois qu'on est habitué, c'est-à-dire qu'on l'a un peu assimilé, comme on se porte mieux quand on mange régulièrement des choses saines. Bon, voilà. C'est pas grave parce que ça arrive dans la vraie vie.
So thank you so much to all the clinicians who shared their stories, but also to the FOP warriors and their families who allowed us to help share their stories. In speaking to the central theme around caring as part of the cure, we encouraged each of the speakers to come up with their own themes and their own stories and to really share those from the heart, which I think you might have seen in the presentation. I'd just like to point out one of them was Dr. Elizabeth Ho's presentation around Kerebetswa. So Kerebetswa is a little girl who's very close to our hearts, and the presentation that Dr. Ho shared was filmed literally a few days before Kerebetswa passed. She passed partly due to complications of FOP, but mostly because she came from an underserved community, the details of which I won't share here, but mostly because she came from an underserved community. So her mother has been very, very determined that her story continue to be shared in the hope that we might find other children and other adults who are living without a diagnosis, many of whom we believe live in underserved communities. So Julia, I don't know if you're online tonight, but if you're not, you'll certainly see this. Thank you for the courage that you have shared and have in joining FOP family gatherings and still being so much of a community as a mother whose child is no longer with us. And Kerebetswa, you're an angel and we love you, and thank you for being with us always. So I see we now have 152 people registered for the webinar. Very big welcome to Ireland, France, Scotland, and Hungary. Hungary, you're new. As I said earlier, clinicians were able to interpret the theme and tell their own stories. For Dr. Marlies Eckhoff, her story is around a centre of excellence in the Netherlands, and her team very generously both filmed and shared the piece that we're about to share with you now, after which the roundtable discussion will begin. So thank you very much. Another 10 minutes of a short film, and then we will begin the roundtable discussion. Over to the film.
Fibrodysplasia ossificans progressiva, or FOP, is such a devastating disease that many secondary problems may arise. To manage this properly and on time, a multidisciplinary team is needed, where all specialists are well aware of the rare disease and are dedicated to work together to help the FOP patients. Such a collaboration is created by working transparently with like-minded colleagues. Also, this takes time. It gives such satisfaction, job satisfaction, to achieve the best care for and together with the FOP patient. For this, you need frequent contact, consultation with the patient is very important to achieve the best personalized therapy and innovative solutions in issues that previously seem unsolvable. My name is Marlies Eckhoff. I'm internist endocrinologist at the Amsterdam UMC. I'm dedicated to FOP since 2011. Also trained in the field of rare bone diseases. The first FOP patient I met at the Amsterdam UMC and caught my eye immediately. While the patients were sometimes completely trapped in a second skeleton, their struggle, energy to life, active mind and sense of humor were impressive to me. Two research models have been developed in Amsterdam, one using a very small skin biopsy and the other using ligaments of teeth that remain after extraction of medical reasons. This allows to set up and investigate osteogenic transdifferentiation in cell cultures, thereby providing more insight in the disease and supporting opportunities to find new therapies.
I'm an anesthesiologist here at the Amsterdam UMC Bone Center, and I'm involved with FOP patients as an anesthesiologist in the entire trajectory of beginning of care up to, if needed, surgery. Together with two other colleagues, we treat many patients from the Netherlands and also internationally from many countries in and around Europe. Young people, elderly, children, we see all types of demographics. It's a varied group. There's also a lot of variance in the severity of disease, from very mild to very severe cases, and we see the entire spectrum. There are certain difficulties that we see in these patients. Also very restrictive pulmonary function can be seen, especially in severe cases. And even so severe that mechanical ventilation is not possible at all. In these cases, general anesthesia we usually try to avoid. As a team, most importantly for any surgery in these patients is that you need to approach it as a multidisciplinary team. So we evaluate these patients long before the surgery is planned, if possible, with the entire team. We also see the patients themselves. Most of them we already know, and the ones that we don't know we want to see before the day of surgery, just to see what is possible, what isn't possible. We try to assess if we want to perform a regional technique. We try to assess if it is possible at all. So we always use the ultrasound on forehand just to identify the nerves to see if it's possible at all to perform a regional technique. It's a joy to work in this team because it's a team made up of all types of specialists that are really enthusiastic about providing the best of care for these patients. It's a varied group with all types of inputs, all types of different perspectives, and I think that as a team we do our utmost best to make the best possible for these patients. And in the years we've gotten to know a lot of these patients as well because we see them regularly for all types of checkups or procedures, and yeah, we just want to do the best for them. Treating these patients takes time. You can't rush it because if you try to rush it, then things go wrong. So you need to take your time, be patient, and usually that's the best. So there's something very strange about the FOP patient because even though they have a very severe illness, that most clinicians that I speak to, you think that having a disease this severe and would make you a bit pessimistic about life, but for some reason they are the exact opposite. They are really positive, and even though they are, if you just look at the disease itself, they are very ill. They have very much discomfort, but for some reason they still keep positive about it. And I think that's a good example for ourselves as well. Well, the problem with needles with these patients is that all kinds of trauma can be a cause of ectopic bone formation, especially needles that go through a lot of tissue, connective tissue, muscles. So in any case, you always want to avoid it if possible. Sometimes for anesthesia, it's unavoidable. Then it's something that has to be done, but with a lot of precautions.
In collaboration with the Imaging Center of Amsterdam UMC, the use of 18F sodium fluoride PET-CT was investigated in FOP, with which we found that we can use it to see whether a flare-up will lead to HO later on, which is not the case in about 20% of the patients where flare-ups solve without any bone formation. The labeled fluor only binds to active bone formation sites through an exchange with the newly formed matrix. And in this way, it's able to detect and quantify the activity of the ossifying flare-up even before you can see any bone on the CT. So this imaging modality is able to be used as a marker for disease activity. We not only show that you can predict where a flare-up will form bone in the future or in a few weeks later, but also we found that there is also a chronic phase of the disease. Nearly all patients have chronic activity of the disease, and with the 18F sodium fluoride PET-CT, we can find these spots and see how active they are.
In the beginning, being a surgeon in a FOP team was a bit strange because surgery in FOP patients usually is a no-go area. But because we see so many patients, we found that in extreme cases where infections, hygienic problems, or severe deformities have no other options besides surgery, the treatment plan that we can offer is becoming more diverse, and with the help of all the research that we do, I think it can become even more patient-centered in the future. So working in a university hospital, we have a big research department, we have a clinical department, and we have a collaboration with several pharmaceutical companies, and that allows the entire team to offer a patient-centered and patient-tailored treatment plan. In my opinion, surgery is the way to go in the future, and I think the quality of life of FOP patients can dramatically be improved if we can suppress the heterotopic ossification flare-ups.
We always work in a team with the imaging radiologists and nuclear specialists, and are involved with the not only with preparation of the patients for the PET-CT, as you can see here, but also we look together to the pictures to really understand what is happening so we can help the patients as good as possible.
Being close to a large airport, Amsterdam is in Europe a very, very central position, and we see a lot of FOP patients from this area. We are an international referral center, and that makes our team more and more experienced because we see so many different patients with a lot of different issues.
We are ready to help them. If they can't, they can always call, or we can have a video consultation, but coming is also possible.
So thank you so much for all the presentations. We realize that many clinicians around the world have given us an extraordinary amount of their time, their technical ability, and also obviously their insights and knowledge. So we are deeply thankful from the CME course. We'll shortly be crossing over to Chris, and who's running the roundtable discussion. But again, I'd like to encourage you all to offer your questions and your comments so that the people, the wonderful guests on the roundtable can respond to them. And now, without any further ado, over to Dr. Chris Scott and the roundtable discussion. Thank you.
Thanks very much, Odette. And I'm coming to you from Cape Town. I'm sitting in my living room, and it may be difficult for me to completely control my dogs, so please accept my apologies if you hear them in the background. It's a wonderful, wonderful evening, a great event, and it's really an incredible time for us to be able to share in the stories of these patients from all over the world, and to see not only the doctors, their homes, their offices, and to get a little bit of the human interaction and the insight into what it means to be a physician and to care for children with rare diseases. And I'm sure, like me, you found the stories incredibly moving, and were moved by the compassion and the passion of the doctors looking after them. So it's not often that you get so many doctors in one room, especially not a dermatologists, metabolic specialists, endocrinologists, orthopedic surgeons, and they all, for once, can agree on everything. In addition to that, we've also got patient advocates of the highest order, Kelly Duplessis and Michelle Davis. So I'd like to start off with the questions soon, and I'd like to encourage you all just to remember to post some more questions. They are coming in thick and fast, but this is a great opportunity to connect with really special people over this topic. So the first question I'm going to put to Fred. Fred, being the senior statesman in the room, there's a question from Motlacho, who wants to know if scoliosis can turn into FOP, or another way, I guess, of saying it, perhaps what Motlacho means is that if you have scoliosis, does that mean you could have FOP?
Thank you very much, Chris. Scoliosis is a very common problem, and scoliosis does not mean FOP. FOP is an extremely rare condition. It affects maybe what we now know 1,000 patients in the world, probably as many as 4,000 or 5,000. We don't know. And patients who have FOP can develop scoliosis. Not everybody with FOP develops scoliosis, but some people can. And they develop it because of the extra bone that forms around the spine that causes deformity, and they can develop FOP because of developmental problems with the joints in the spine, or the joints that join the ribs to the spine, and so that can lead to scoliosis. But common scoliosis does not lead to FOP. FOP is a genetic condition, and it's caused by a gene that has one misspelled letter out of 6 billion that causes this condition. So although scoliosis is commonly a feature of FOP, scoliosis does not lead to FOP.
Thanks very much. That's very clear. My next question is going to be to Kelly, I think, and perhaps Michelle would like to follow on. Kelly Duplessis from Rare Diseases. Someone's mentioned here, Karen has mentioned that she's just connected with a young 13-year-old girl in India today who has no resources. She's watching with me right now, seeing other children with FOP for the first time. Let's help her and others in the worldwide community to get connected to resources, says the comment. So, Kelly, my question to you, and Michelle, if you could follow on, what do you think it means to patients to connect with the big community? Kelly, your experience in rare disease, You've obviously got an organization that connects many rare diseases. But what does it mean to people, and how the alternative is, what does it mean to not be connected and to be isolated and to think you're the only person suffering from a rare disease? Perhaps you can give us some insights that you've learned from the community.
Thanks very much, Chris. You know, if I can relate it back to that age-old saying, "It takes a village to raise a child." In the rare disease community, without that village, it's a hopeless scenario. And I see numerous times a year, you see children who meet other children, similarly to the patient sitting in India tonight, who for the first time can recognize their uniqueness in somebody else. And the value of knowing that you simply are not alone and that there are other people in a community who get it is insurmountable. It's something that is not tangible. It's knowing that you've got a family besides you, and very often you get the very practical expertise from other patients that you wouldn't necessarily get from your clinician or your physician, simply because they know it, they've lived it, they've gone through it, and they experience it every day. So they'll be able to really break it down in a way that is palatable for someone who's going through such a tough journey.
Thanks very much. Michelle, would you like to comment on that?
Yeah, I would just add that, you know, there is the ability to connect with other people ends that isolation that you feel when you haven't met other people with that disease. And so it's important in that way, but it's also important from a way, I mean, that was how the IFOPA was founded. People wanted to end the isolation of living with FOP. They wanted to ask one another questions. How do you put your own clothes on? How do you eat your favorite meal? How do you interact with your caregivers? How do you hire caregivers? And so when you connect within a community, you open up this vast level of resources that you don't have before. And there are organizations on the IFOPA's website, on the main page, it says FOP National Organizations. And when you click on that, it will link you to national organization connections in more than 20 countries. So you can find either an individual that's running it, that's connecting with patients in that country, or an actual organization that's been set up as a nonprofit or an NGO that you can connect with. And there is one in India, so we do hope that the patient there will be able to get connected to that group. Or in the case, another great resources are the rare disease organizations. They may not be FOP specific, but they're also very, very important organizations like Kelly's.
Thank you. I want to take that question and throw it over to Carmen and ask her. Kelly mentioned that parents can explain to children and to other families what's going on and break it down into understandable bits. But very often, and I'm sure this has been your experience because I happen to know one of the parents of one of your patients, the parents become the experts in the disease and the experts in the room. And that was, can you tell us about your experience with that, and how important is it for the parents to become the experts and to be the advocates for their children? Because if they end up in an emergency room where people have never heard of FOP, for instance, they're the expert. And I believe they're the expert in most situations, actually.
Well, that's right. It's a very good question, and it's a situation that replicates everywhere. And sometimes some physicians can take that patients know that more than what physicians know. But some physicians, they don't like that. They don't like that situation. But actually, for many, many rare diseases and chronic diseases, the people that know more about the disease and what happened with their child are their parents or their caretakers. So we have to encourage that, and we have to listen to them. Even if we don't have, for example, when they go to the consult and they tell us something that we cannot really verify at that moment, we have to listen to them and see and listen what happened at home, what happened at school. So I think it's very important. That's the way we have to work together at the same level with the parents. So we have to be alive. We have to be very, really in touch with them. very close to them, and with the children also.
Thank you. Thanks very much. Another comment here, and I'm going to put this one over to you, Patricia, because I think you're the person in Brazil with the biggest heart. Well, you've got the biggest heart in Brazil, shall I say. I'm going to say the comment goes, FOP is surrounded by the most inspiring physicians and community members on a global scale. Thank you to the physicians that take such good care of our community members. You give us hope. I'll read the rest of the message in a bit, but Patricia, what do you think it is about this community of disparate physicians that makes one passionate about FOP, or that makes one care for FOP patients? Because in my experience, I can only agree with the comment that it really attracts a certain type of individual and I like all the people in the FOP community. I don't know why. So maybe you can talk to me about what drove the passion and what makes you passionate about FOP.
Thank you, Chris. Well, I think that at the beginning, a lot of doctors would say, hey, this is FOP, a rare disease. I can publish this, or I can relate what I'm seeing, tell other doctors what I found. But when you start to get involved, you really feel that there is much more than this. When you feel that giving hope makes a difference to a family, changes lives, that's why you are a doctor. That's what I think. So science is part of it, but if you don't put your heart, you don't put lives. And yes, I saw someone that was asking if we believe that there's going to be a treatment. I believe that since the year 2000. So each year, I believe more in this. So hope is the key of it all. If a doctor has the desire of helping, he's going to give hope and change lives.
Thank you. It's very inspirational. The last part of that message was just a message to Julia and to Kia, and I want to take the opportunity just to say that that this evening we're thinking about all the families who've lost children or relatives to FOP, and our thoughts are with you, and especially Julia, since we heard Kiribet's story this evening, wherever you happen to be. All right, the next comment, Fred, if I could ask you to unmute your microphone, was to you. And it says, it's from someone called, from Sharon. Sharon, who says, when I first met Dr. Kaplan, I left him speechless. When I asked him why he was interested in FOP, when I asked him why he was so interested in FOP, now, first, I can't imagine you speechless, Fred, but apparently it took you a week to reply, and then you sent her a nice letter, the William Harvey quote, that she had cross-stitched for you now is hanging in your office. Can you tell us the quote and tell us why that means so much?
Sure. Thank you, Sharon. I'm not in my office. I'm at home now. I'll try to remember the quote. It's a great quote, and I think it says, nature is nowhere more likely to display her secret mysteries than in cases where she shows workings apart from the beaten path, nor is there any better way to practice the medicine than to give your mind to the rarer forms of disease. And the reason that this was a letter written by Dr. Harvey in the late 1600s. Dr. Harvey he made probably one of the greatest discoveries in the history of medicine. It was the circulatory system. He discovered the circulation of blood, the closed circulation of blood. And as he got older in life, he was asked by a doctor in Haarlem in the Netherlands to come and see a patient who had a rare disease. But Dr. Harvey was very ill. He couldn't go. And he said, I think you should pick somebody younger. It's very important. And then he wrote these what I think are some of the most prophetic words in medicine. Nature is nowhere more likely to display her secret mysteries than in cases where she shows her workings apart from the beaten path, nor is there any better way to practice medicine than to give your mind to the study of the rarer forms of disease. And the reason this is true is because nature doesn't invent new genes and molecules and cells and tissues and organs for common diseases, but it's the fidelity of those rare diseases that lets us understand the pathways that nature takes to get to cause these diseases. And it turns out that these are used by common diseases as well. So the rare diseases are really the clue that helps us discover the common diseases, not necessarily the other way around. And so the rare diseases are the keys to the closet, and they turn out to be the keys to the kingdom.
Thank you. That is indeed a lot to think about and digest, and makes me feel a bit better about caring so much for rare diseases. The next question, Marilise, if I could pass this one on to you. It's from Kaya, and he says his daughter is developing other symptoms. For instance, which I'm finding a lot more challenging to deal with. For instance, last night she mentioned that at school recently she finds herself having to stand a lot more than she used to. This happens now every 1 to 2 minutes, as opposed to every 20 to 30 minutes before. This now leads to other parts of her body being strained because she feels compelled to stand so often. Can you talk about so his question is, what can be done to provide some comfort? So I guess what I'd like to add to that is perhaps you can talk to us about the ways and the mechanisms that you can make FOP patients feel more comfortable, because sometimes they end up in uncomfortable positions, and also this need to stand possibly reflects some disability or some progression of a disease. Perhaps you can comment on that and tell us what you think.
Thank you very much for the question. Not an easy question though. If she feels that her body is changing, we now know that the disease is not only developing via acute flare-ups, but as we have shown by the 18 fluoride, sodium fluoride PET CT, you can see that the disease is also going on chronically. So there might be a chronic ongoing of heterotopic bone, and that might cause changes in her body and how she feels. So it would be good to investigate that. It's very important that she tries to lay in the most comfort way and every time change her body and also change the pressure on her body. I hope that this question or this answer helps and is an answer to her question.
Thank you. I think that is very accurate and helpful. I wanted to ask you. You mentioned pressure on her body. Can you just say something about pressure sores and the risks for developing pressure sores in FOP?
Well, I think we have to divide it in maybe 2 pressures. For everyone, if someone is laying down on a bed and doesn't move, he will have a pressure and wounds developing. But especially if you have some heterotopic bone that is changing the normal pressure that is divided over the whole body, you can have on that spot, especially there, they are more prone to developing wounds. So it's very important that nurses or caregivers look the way the people are laying in their bed. I think it's extremely important to prevent any problem of the skin that is over an heterotopic bone.
Thanks, Marilise. The next question, Elizabeth, I'm going to go your way because I recall that you mentioned it in your. I hope it was you mentioned it in your patient presentation today. And the question is from Amanda Kelly. Can the doctors explain the benefits of using a spirometer to help with lung health and lung capacity? And is there anything patients can do to increase their lung health, especially if they don't have access to supplemental oxygen?
Thanks for that question, Chris. Yes, there are things that you can do to improve your lung health. Well, I'll start off with the spirometer. It's basically, a spirometer is a little gadget that you blow into. You take a deep breath and blow into, or you suck your breath in and you see a little ball moving up and down, or it could be a little whistle that goes off. And basically it encourages you to expand your lungs so that you keep your rib cage mobile and not so stiff. So the deep breathing does help. So that's a good exercise to do. And
are there other things that people with FOP can do if they don't have access to spirometers, for instance?
You could practice singing or deep breathing exercises. So Dr. Kaplan always mentioned you should join a choir. And also to avoid infections if possible. So in this day and age of COVID, we all know that we should keep sanitizing our hands and wearing a mask if you're in a high-risk area. Also, if you do develop an infection, to seek help early, because you don't want to leave it till your infection becomes worse. And also to keep up with your vaccinations, such as against pneumococcal and annual flu vaccines. And we just have to be careful of not giving the intramuscular vaccinations for that. And also, looking after your body, so avoiding smoking and pollution if possible, and keeping your whole health as healthy as possible. So looking after your nutrition and doing regular exercise if possible.
Great, thanks very much. Geneviève, the question also mentions supplemental oxygen. And I bet a lot of FOP families are suddenly wondering, well, how do I know when my child or the person in my house living with FOP or the FOP patient themselves are wondering, when do you need supplemental oxygen? How would you know, and how do we make that determination?
Thank you, Chris. This is very important to explain that oxygen might be dangerous for people with FOP, whatever be the age, especially because if you have a chronic pulmonary disease, FOP or another, you will, when you have a balance between oxygen and carbonic, the CO2. And when you have a low level of oxygen, you breathe, and with that, you diminish your CO2. And the CO2 is toxic. You have to, it's dangerous to have a high level of CO2. So it is important to divide chronic problem and acute respiratory problem. In FOP, usually when you have a chest involvement, you breathe a bit more, you have a higher respiratory frequency, and if you give oxygen, you will diminish this respiration frequency, and the risk is to have a higher level of PCO2, which is dangerous for with many complications. And the classical story that we could see before the knowledge that we have today was that in case of acute problem, for instance, asthma crisis, infectious pulmonary infection, or other cause for pulmonary insufficiency, the child or the adult, it is the same problem, go to the emergency department and receive oxygen, and he slowly but surely will have a better O2 level, oxygen level, but with a higher PCO2 and complications due to that. So the rule is to avoid oxygen, and if you have to give some oxygen, to keep a very slow dose of oxygen with PCO2 monitoring. Probably Elizabeth, you may also complete what I just tried to explain. So just the rule is to remember that oxygen may be dangerous and has to be given with ready caution.
Great, thanks
Yeah,
very
I
much.
agree. I agree with that, Geneviève, absolutely, and also what Elizabeth said about spirometry is exceedingly important. The stimulus for breathing is really carbon dioxide. It's a major stimulus, and I think children know this. Children who don't have FOP, when they get mad at their parents, they say, "I'm going to hold my breath until I die," and they hold their breath, and eventually they start breathing again. When they hold their breath, the carbon dioxide level builds up in the blood, in the fluid bathing the brain, and it stimulates the brain like that to breathe. Well, with FOP, because of the stiffness of the chest wall, because of the extra bone, and because the joints don't form properly in the chest, that carbon dioxide level creeps up very slowly. It's like the old adage, you know, if you put a frog into boiling water, it's going to jump out. But if you put a frog into water and you just raise it 1 degree at a time, you can cook the frog. And it's basically the same thing with FOP. The CO2 level just creeps up very, very, very slowly, and you lose the main stimulus to breathe. Well, if you raise your oxygen by taking supplemental oxygen, as Geneviève beautifully pointed out, you completely shut off the stimulus to breathe. It's like in an airplane. You don't pass out because you don't stop breathing because your oxygen is too low. You stop breathing because your CO2 is too high. And if you take oxygen, then the brain says, I don't need to breathe anymore, and people die. And especially if the CO2 level is elevated. And we know in FOP patients that it is. So what we found over the years, and Dr. Grunwald has pointed this out to me as well, what we found over the years, and Dr. Grunwald, I think you've heard from before, he's one of the anesthesiologists and experts on FOP. And he said that if you breathe against pressure, you, like in a balloon, like a straw in water, etc., you help expand the chest wall. And this goes back to what Elizabeth said with spirometry, because the chest is so stiff because of FOP. It turns out that the diaphragm isn't involved with FOP, and it doesn't get involved with FOP. We don't know why. It's a big mystery. We have some suspicion as to why, but we don't know absolutely why it doesn't get involved. And the spirometry helps exercise that muscle. It's like going to the gym, but exercising that muscle. And that diaphragm raises and lowers the lungs and can expand the chest wall very well. So it's important to use spirometry. As Elizabeth said, it's important, it's urgent not to use supplemental oxygen for FOP. There are other ways, and the pulmonologists are aware of other methodologies that can be used to get air into the lungs and to get proper oxygenation rather than using supplemental oxygen. So I think these are extremely good points that Geneviève and Elizabeth made. So
Thanks very much, Fred. Thanks to all of you. Thanks for that very comprehensive answer. Kabashni, this is yours. I'm so glad we have a pediatric endocrinologist on the floor. The question is there a link between FOP and early and premature puberty?
Good evening, everyone. Thank you for the question. Yes, so being an endocrinologist, hopefully I will answer it well enough. So I think that FOP, and if a child has precocious puberty, it is actually probably unrelated, if everyone agrees with me as well. And if the child does have precocious puberty, then we have to investigate the child further. And if the child is less than 8 years in a female and less than 9 years in a male and has secondary sexual characteristics, also has menses in a female, so the secondary sexual characteristics will be breast development, pubic hair. So if they do have all of this present, then they definitely warrant investigations and should be referred to a specialist endocrinologist. The causes might be due to central causes from pathology in the central nervous system, or it may be idiopathic, as we say, which is unknown, or it may be peripheral causes from ovarian abnormalities, or in the male child from testicular abnormalities or rare conditions that cause precocious puberty. So I think in this case, it would be unrelated if a child does present with precocious puberty and would warrant further investigation by a pediatric endocrinologist. Thank you.
Thanks very much. That's a very clear answer. And I just want to mention we've got a lot of questions. We won't get to all of them. They've suddenly started flooding in. So we're going to be quite quick about our answers, I think, going forward, to try and get as many in as possible. But if we don't, we'll try and answer them for you in some way through the Tin Soldiers mechanisms. I'm sure the fairies can do that. So Carmen, the next question is just a quick one for you. Someone wants to know, what is the ICC?
It's for me? Okay. Well, the ICC is International Clinical Council. It's a group, and we are all of us part of this the group, or most of us, of clinicians, and clinicians and dentists. They are interested in the care of FOP patients. And we get together, we are divided in different subcommissions or subcommittees, and we are very keen to talk about ethic problems, about clinical trials, about publications related to the disease, and with the main objective of being care for the security and the safety of the patients and the families, and to be like a bridge between the community and the people that are doing research too. So it's really broad, all the objectives we have, and I think Dr. Kaplan can talk more in detail of that, but it's a place where we can discuss things, and we really share all our experiences with patients. So it's an important group, I think.
Thanks, Carmen. Michelle, I'm going to pop over to you quickly. Can you tell us about the global programs that the IFOPA has? So global programs with global reach. I know you have many, so maybe you could just highlight them for us.
Sure. So the IFOPA is the International FOP Association. And while we're based in the United States, we do provide programs to families and to physicians and researchers throughout the world. We just finished this last weekend, a virtual family gathering. It was a 3-day conference full of talks about clinical trials and research updates, but also very practical topics like pain management and complementary therapies, and then how do patients and families use tools to live more independently. So that is an example of a big program that we do. But if you go to our website, you will also be able to connect to our YouTube channel. And on our YouTube channel, there are lots of programs under the section resources for living with FOP. You'll find lots of talks from past family gatherings that you can watch as well. We also offer a program called Ability Toolbox, where we will help consult with families. Karen Kirchhoff on our team runs that program. We will consult with families about maybe limitations that they are experiencing as bone grows. And then what are some ways, either through purchase tools or homemade tools or home adaptations, that they can actually do more for themselves and live more independently. And that's helpful because it's good psychologically for the person living with FOP that they can do more things for themselves. And it's also good for the caregiver to not have the burden completely on them to be caring for the person living with FOP. The last thing I would mention is that we have a program called the Harold and Elaine Kaplan Life Awards. And it is a program that provides each individual with FOP a lifetime grant of up to $1,800 US. And they can use that grant to purchase items to help them live more independently. Maybe they need to put that towards a wheelchair. Maybe they would like to make adaptations to their home. A woman in the UK redid her kitchen so that she could cook for herself. Or sometimes people will use it for tuition. Maybe a laptop will help them stay more connected, or to do a vocational job or another job that they have. So those information about all of those programs are available on our website. And they're available to people living in the United States, but also to our global FOP family.
Great, thanks very much. Kelly, are you aware of other programs in rare diseases that in places where people haven't got a local FOP community? Do you think rare disease organizations have a place, or do you think we should be connecting with families with rare disease, all patients with FOP, with other rare disease groups?
So I think
Sorry, if you could just start again, Kelly, you're just breaking up.
one of the challenges, particularly in the South African context, is the 12 official languages. So I think languages and culture remain a barrier. Sorry. And I think that makes it particularly difficult in the African context. So a disease organization will be able to give you the in-depth knowledge on a particular condition, but they will be able to give you broader coping mechanisms and broader support. And then they can obviously liaise with the international groups where possible to translate the relevant information through to making it understandable. The cultural differences across obviously from a global perspective are huge. And I think very often the struggle of the developing countries is missed in the global context, simply because of the fact that, we are so rural and so far behind the times in so many aspects, that the advice and the resources that are often made available from an international perspective seem way out of reach, and never local support is also critical. But obviously disease specific information is really fundamental to understanding your disease pathology and ultimately understanding the progression of your condition.
Thanks. So what I hear is that rare disease organizations can act as an extra bridge between the IFOPA and local, and especially where there are language or other barriers and no local FOP champions. So working together is what we do clearly quite well. Marlies, thank you for those answers. Marlies, there's a question here that asks about surgery and whether Amsterdam UMC is the only unit currently that's doing surgery. And the question is, how do you prevent flare-ups with surgery? So maybe you could just talk to the question. I don't know if I got the wording right, but I'll read it again. Is the Amsterdam UMC the only one considering an option of surgery to address serious FOP situations? And how are they able to do this without causing further flare-ups and worsening of the condition?
Chris and all, thank you very much for the question. No, we are not the only center. There are more, but it is important that we all collaborate and share experience. We work, as you already have seen, with a multidisciplinary team, and you need surgeons and anesthesiologists who want to take time to prepare, because you really need quite a lot of time to prepare together with the patient how you can perform the surgery best, and also you need a lot of time during the operations. Well, we can tell a lot about our experience, and I would like the anesthesiologists and surgeons to tell that. But I can tell that we took during the last surgery local anesthesia with a prednisolone protection, and we can tell another time more about it. And also the way of ventilation. The anesthesiologist well developed an inventive way how to do it with someone who has a very, very worse or bad lung function, and still could go through very well through the surgery. So it takes a lot of time, collaboration with many disciplines. We're not the only center, and there are more. And yeah, we and others are thinking already ahead for the coming procedures and how we can do that best. And we need to share with each other all the experience. That is very, very important.
Thanks. So just in case there are some people who've just tuned in and are new to FOP, so just, Marisa, I just want to get this right so that people don't get the wrong impression. But surgery is contraindicated in most patients in FOP, but there are certain very specialized centers that can do surgery in very specialized circumstances. And in the future, when we potentially have therapies that can abrogate that can work against the recurrence of bone formation, we may be able to reconsider that. Is that right?
Yes, Chris, thank you so much. Yes, of course, at the moment, we don't have any therapy. So if you perform a surgery, you definitely will have bone formation, new HO, and probably more than before. But in cases where it is really necessary to keep a person alive, a patient with FOP, then you can consider a surgery to and we did, and a few times really to help the patient stay alive. And then you can take the precautions and you have a team to do it. But surgery, just surgery, no, it's not possible. We are looking, and we need medication that really works, and then we can start the following step. And then still it will be difficult because you can't just take out all the HO. You have to think what you are going to do and how you replace. So it's a way to go, but there is hope and there's future. Thank you so much for your comment, Chris. Yes.
Thanks very much. Okay, guys, it's time for us to start wrapping up. Just two things I want to mention. The first is any questions we didn't get to, we are going to post on the Tin Soldiers website, which you all will be accessing. And I just want to make you aware that Michelle's also posted here the list of country leaders that's available on the IFOPA website. So if you go to www.ifopa.org and look for FOP_international_organizations, you can find a list of people who can help you in your region or in your area. So it remains to thank you all very much for a wonderful session. I think it really went particularly well, and sorry we didn't get to all the questions and we didn't get enough time for everyone to speak a lot, but I do think we had an interesting discussion, and to the Tin Soldiers team and all the fairies behind the scenes who've made this wonderful technological marvel happen, we'd like to thank you as well. And with that, I am handing over back to Odette. Thank you.
So I believe we're back in South Africa, and wow, what an amazing, robust session. And thank you to everyone who've posted all your questions. I know we didn't get to answer most of them, well, a large majority of them. So all of those answers will be on the Tin Soldiers website, which is www.tinsoldiers.org. So we will post the questions, we will get the experts to answer those questions, so they will be there for you. For all the healthcare professionals, don't forget to log into the Global CME Series platform so that you can log in and engage and also get your points for these sessions. But most importantly, I'd really like to thank every single person who has joined this journey with us. It was an experiment for us, putting this series out through COVID. It was a massive experience, and the fact that you've all joined us is just massive. And to all the healthcare professionals who've joined us, know that you are part of a community of over 300 people who never knew about this condition, or maybe partly knew about this condition, and now you're part of a community. And we trust that your eyes are on the lookout so that no one else with this condition will suffer an undiagnosis. So for that, we thank you very deeply and very gratefully. And in finally closing, I'd just like to very much thank this massive team behind Tin Soldiers. I think all of you kind of see me, and I'm just this teeny part of it. There are countless crew, there are countless editors, many of whom can't even be counted tonight. But there are also the people who are sitting at home, who direct our strategy, who direct our communications, Vanda and Renelle and Helen, who looks after making sure everyone gets paid. And finally, the people who are in the room tonight, I'd like them to have a little shout out. That is Nikki from Operations, and Grant from behind the camera, and our technical team, Massimo and Henry, just to say good night, good luck, and thank you. And with that,